Hi, it's Dr. Centeno. Still battling a little cold here, so just wanted to give you a heads up. Thanks so much for joining us today. I'm going to talk about an interesting topic today. As you know, sometimes I'll talk about what I experience on a day-to-day basis. So a patient had asked a question via email this week. He was having some graying out episodes with turning his head a certain direction, and had basically said that someone on Facebook had told him that he had Bowhunter syndrome and may drop dead. So obviously, it's definitely something to bring up and something to discuss. I told him I didn't have that same concern. And obviously there are issues with getting a diagnosis over Facebook. But I wanted to bring it up and just talk about it a little bit more formally, because there are CCI patients that have a hard time with graying out or partially losing consciousness or even fainting altogether with specific head positions. Sometimes it's not so clear that it's related to specific head and neck positions. So it's out there. So that's what we'll be talking about today. As usual, I'll do a short presentation, maybe 5-10 minutes, and then answer questions. We had a lot of questions that were pre-submitted. I suspect that because I was in the Caymans for the last 2 weeks, we were doing it that way. Now that I'm back here in the US, and will be for quite some time now, we'll be doing this live at 1 p.m. And so that'll be usually on Mondays and Fridays, and that's 1 p.m. Mountain. So that's 3 p.m. Eastern and noon Pacific. So let me go and share my screen, and then we'll get started with that short presentation here. Okay, so I'm going to start here and talk again about what can cause graying out or fainting in CCI patients, because we have about, I'm going to estimate 5 to 10% of our CCI patients, sometimes it may be up to 1 in 5, that have this problem or something very similar to this. So again, I'm going to estimate right now that we're talking about the minority of CCI patients. So I'm going to put this at somewhere between, depending on the week, the patients that we're seeing in the office, 5 to 20% of patients have some element of this. And that may just be a graying out episode where they feel a little lightheaded and they start to feel like they're going to faint, all the way up to actual fainting, losing consciousness, that kind of stuff. So a patient recently brought up that he was told on Facebook that that was evidence of Bowhunter syndrome and that he could drop dead in any minute. Now, I didn't have the same diagnosis after communicating with him over email. Obviously, it's impossible for me to make a formal diagnosis without history, exam, imaging review, etc. But I didn't have the same concerns, and there's a reason why I didn't have the same concerns. So obviously, if you have any kind of fainting, there's lots of things that have to be worked up. And the two main things would be some sort of heart problem, arrhythmia, other issues with the heart not pumping blood to the brain. There's obviously neurology concerns, lots of different neurologic diseases that might cause this. So an MRI of the brain would be pretty key, brain tumors, et cetera, and other things. So what we're discussing today are those patients who have had this kind of workup and they're not finding anything. And they've been told they've got CCI. So could there be a relationship, and what could cause that? So again, once all these things have been crossed off the list, what could cause this kind of problem that's in the neck? So lots and lots of different things could fall into this category. For brevity today, I'm going to focus on 3 large categories. the vertebral artery, the vagus nerve, and proprioceptive. Now, vertebral artery, this patient was told that he had Bow-Hunter syndrome. Now, Bow-Hunter syndrome is this idea that there's enough dislocation. So this is, let's just write this out. That's C1, that's C2. This is the vertebral artery that goes through C1 and C2. And you can see that the vertebral artery goes through these holes in the bone here and here, and those holes are made up of C1 and C2. Now, if you're in a situation where you have severe amounts of motion occurring at C1 and C2, and or you're in a situation where there's abnormal stresses on the vertebral artery, that can traumatize the artery, and that can lead to fainting episodes. However, I've spent a lot of time treating patients with fainting episodes through the years. And while it's always important to rule these kinds of things out, we rarely find them in this patient population with CCI. So while it's possible he could have Bow-Hunter syndrome, it's by far not the most likely explanation of what causes that. And that's one of the problems with Facebook diagnosis, right? Someone looks it up on Google. Next thing you know, they're getting a diagnosis and diagnosing another human on Facebook without really the knowledge, the background knowledge that comes with that Google search. Another thing, and going back just briefly here to vertebral artery. So this is not the only thing that can go wrong with the vertebral artery. Certainly you can have a vertebral artery dissection where you get a ballooning out or an aneurysm of the vertebral artery. There are also small little nerves that live around the artery that in our experience can get irritated and then lead to just very quick spasm within the artery. And imaging this is not so easy. Early on in my career, we tried to image many patients with regard to the vertebral artery and turning their head, and it's not trivial. It really takes a skilled interventional cardiologist or interventional radiologist who can get this image right. Then we've got the vagus nerve. Now here I have this blue thing, which usually represents a vein. So this is the internal jugular vein. But the vagus nerve travels here as well as glossopharyngeal nerve, etc. So I'm going to draw that in so you can see that the vagus nerve lives right in front of that C1 and C2 right here. So again, instability in the upper cervical spine can lead to irritation of the vagus nerve. Now, the vagus nerve is also responsible for vasomotor activity. And what that means is telling the arteries in your body to contract or relax. And if the message is to relax and appropriately, that can cause a sudden drop in blood pressure and the person can lose consciousness. And that's kind of how fainting works, right? Fainting works the same way, is that a bad signal is given and that opens up blood vessels and the blood can't live up here anymore, so it drains down into the open vessels. So vagus nerve can certainly do this. And then finally, we see a lot of patients with proprioceptive issues. So realize that there's all this stuff that has to be coordinated. So that's visual input from your eye gets coordinated with information from your inner ear that gets coordinated with information from your neck position. And all of that talks to each other through the brain. So there are all these reflexes that go back and forth between these very systems in very complex ways. And so they talk to each other. And when they're not in agreement, that can cause some pretty weird sensations. The most common would be dizziness or imbalance. But I have seen patients where I'm pretty convinced where this mismatch is leading to them feeling like they're graying out, meaning there's so much bad input coming in that they get to that point. So one of the things to consider here is, I've been seeing patients with upper cervical issues and CCI type syndromes going back several decades. And I've had a lot of patients through the years that have this problem. And I haven't had any, however, who have dropped dead due to Bowhunter syndrome. Is it possible? Again, it's always possible. We can do things like MRIs and MRAs to look for the really bad stuff. And obviously, there may be somebody out there that this happens to, but is it the most likely explanation in a CCI patient? It is not. Nor is it common that a CCI patient is going to drop dead from something like this. So again, just realize that the bigger risks are not that you're going to end up in the ICU or you drop dead from this, but the biggest risks are the common things like falling or driving when one of these episodes is happening. Those are the things that concern me, and those are the things that would injure these patients much more than dropping dead from a Bowhunter syndrome. So in summary, these issues should be worked up and taken seriously, obviously, but they're not usually caused by things that also cause patients to die suddenly. So just realize that a qualified physician should be working all this stuff up, or physicians or specialists, but also take Facebook diagnosis with a grain of salt and see someone that's seen a lot of these patients and can put it in context for you. So I'm going to go to questions now. Let me end this here, and I will get to some of our questions here. Bethany, hi, Dr. Centeno. I'm flying out tomorrow for my PICL. Great. And Wednesday, and wanted to know if you have found a way to tolerate or to treat the ALCAL plexus directly at the same time as PICL. Bethany, I don't think that's needed right now. There would always be a risk in damaging the plexus. So I think the better approach is to try to deal with the instability that's irritating the plexus before we do that. Bethany, how do you determine if someone has vertical instability or horizontal instability, ADI, BDI, BAI measurements? Are you able to calculate these measurements or imaging before you do the PICL procedure? Bethany, it's not really important to me whether it's vertical or horizontal. The goal is really still the same, to tighten down the ligaments to try to reduce the instability. Of those measurements you have there, none of them have what I would call adequate verification that they're normal and abnormal. And there's past lectures I've done on that. I'll probably do one again here sometime soon because this keeps coming up. And that is, these are all measurements that we kind of think are probably abnormal, but that research has yet to be done in any elegant way. So of the measurements we use, a C1, C2 overhang does have that kind of data behind it, but a BDI to BAI does not. So we got to take it with a little bit of grain of salt when we're using measurements that haven't yet been fully validated. Regenics, Min Advanced by Edward Chen. If someone has a PICL that didn't have symptomatic improvement at 4 months, but theoretically would have at 5 or 6 months, would getting a second PICL at 5 months reset healing for number one, have their procedure close together compound their effects? Generally, in our experience, the vast majority of patients would have responded by 4 months. So it'd be fine to do this at 5 or 6. Now, is it possible that in a small percentage of patients, they might not get an effect till 5 or 6 months? That's certainly possible. Do I think that's going to injure anything or cause any problems? No, by getting a second procedure. Edward Chen, is it possible to get CCI from poor posture? I've seen patients who are pretty young who don't have EDS or a clear traumatic event develop CCI confirmed by DMX with no clear reason. Poor posture may not be the right terminology. We certainly see that patients who have a reverse cervical curve can put a lot of stress on the upper neck ligaments. So it's probably a combination of that and something else, like some trauma, that led to the CCI, or stretchy ligaments plus that, et cetera, et cetera. So by itself, probably not. If one needs a repeat DMX post-PICL to check if progress is made on instability, would only the views that show pathological measurements be repeated? Yeah, that's what we prefer. So if you're working through Dr. Katz, he generally understands that. I wouldn't repeat the whole DMX. I don't think there's much rationale to repeat the whole DMX. Edward Chen, if the ADI closes in extension to become temporarily normal, would someone who has a problematic ADI have relief of their symptoms if they tilt their head up? Maybe. You have to realize that there'd be two instances or conditions, if you will, for symptomatic cause and effect. One would be that the person's in that early stage of their problem, where if something is actively aggravated, that leads to symptoms directly, in which case you would be right. But there are also patients who have had these problems long enough where these structures are damaged enough where there isn't that clear connection anymore between movement and symptoms, because the structure's already been damaged. So it all depends on where that person lives. Edward, at what point does CCI become a surgical issue in terms of DMX measurements? I'm not sure there's anything on the DMX. Well, that's not true. So one of the areas where we can get concerned is if we see a very big ADI. So I'm talking about an ADI of 10, 12 millimeters. In that case, I will refer that patient to a neurosurgeon first. Now, interestingly, I haven't had many neurosurgeons bite on that, and they refer them back. But that's where I tend to get concerned. When it comes to overhang, not as concerned there with regard to degrees that are definitely surgical. But we certainly see patients where they've got enough static compression on their MRIs or there's just abnormal anatomy to begin with, severely abnormal, where, again, I think they're more surgical candidates based on that. Edward, how should one prepare for diagnostic facet blocks? Would fasting be required the night before? Shouldn't be required unless you're getting anesthesia for diagnostic facet block, in which case anesthesia in our clinic is no eating for 6 hours before and no drinking for 2 hours before. Fat Chun, defining instability doesn't mean that C1s2 have moved from the normal position and will not return to normal alignment until ligaments are tightened, or it means that C1s2 constantly move or outside the normal alignment. Instability is defined as abnormal movement of that area with movement of that body part. So the joints are moving in abnormal ways beyond their normal physiologic motions in that direction. That's what instability is. And regrettably, a lot of the surgeons, since they don't use movement-based imaging, have tried to take that movement-based concept of instability and move it into a static image, because that's what they're used to looking at. But regrettably, instability is a movement-based concept. It can only be seen with movement. Now, there are some exceptions when the instability is so severe and the bones are so misaligned on a static image that it's clear that there's instability, but that's generally not what we're talking about in this patient population. Fatchen, not sure if I answered previously. I know the opposite is not true. How often do you see a CCI patient that hasn't lost a neck curve? I would say the vast majority of our CCI patients have lost their neck curve, But also realize that there's a high percentage of the adult population in the United States that has lost their neck curve as well, just because we tend to do this all day. So hard to say that one's causal of the other. Fatchen, is there a treatment for retrolisthesis in lower cervical spine, and when is it recommended? What role does this condition play in overall cervical instability? There is a treatment for retrolisthesis, and that would be tightening the anterior longitudinal ligament. It's not a procedure that is in the same risk category as just tightening the ligaments back here. It's at a higher risk category. And hence, we only do that when we really think that that's causing symptoms. If we don't think that that's causing symptoms, we'll generally leave it alone because of that higher risk category. Again, everything in medicine, and you'll hear me say this time and time again, is risk, benefit, risk, benefit. How much risk am I exposing the patient to? For how much benefit do I think I'm going to get? And that calculus has to work out. Hi, Dr. Centeno, Alexander. I feel my nerves are really irritated as a result of the CCI. Epidurals have been really effective for me in other spinal levels. Would it be possible to do epidurals at the C1-C2 nerve roots or via the front with the ALR injections? It's not really possible to do a C1-C2 epidural in the same sense as you would do one at 5-6. You can do a selective nerve root block and realize that the stuff we inject, if we're coming from the front, is going to go around that epidural space anyway. So it's going to have an epidural effect there. So the answer is it's all possible to do, but it's all risk benefit. So a direct epidural at C2 would be a C2 dorsal root ganglion block. And there's a certain risk benefit with that that has to be looked at. Fatchen, during a PICL posterior PRP procedure, are vital signs like heart rate and blood pressure monitored real time? Yes, so we monitor heart rate, pulse ox, blood pressure, all of that stuff is monitored during a procedure like that. It's been advanced by Tamara Field. When I look down, I almost pass out. Yeah, Tamara, so the thing that we would look at is to try to see if you have a widening ADI, or there might be other things that are happening to your bones relative to those nerves or arteries when you're looking down. Liam, hi, Dr. T, do you have any issue with the patient doing audio recording during the imaging review physical exam portion of the PICL day? No, that would be fine. It's been advanced by Edward. Some members of the PICL group report that they begin seeing improvements after the 4-month window. For instance, they didn't start seeing improvements till after months 5, 6, or 7. At what point after the procedure is it safe to throw in the towel and say you've got most of the effect? Yeah, the best you can do there with all procedures, not just this one, would be to draw a bell curve, right? And, you know, we all maybe remember the bell curve from when we were taking high school math. Well, it's hard to do, but it's obviously like this. I'm trying to follow my finger, but my finger's going backwards. It's obviously like that. So a bell-shaped curve would have most of the people in the middle. So for most of the people after PICL, from what we see, they would get a result by 4 months. Now there's the two tails of the bell curve. On the one end of the tail, we would see people that are getting the smaller percentage who are getting symptomatic relief well before 4 months. And then a certain small percentage of people who are getting relief well after 4 months. So it's certainly possible. And that's generally how medicine goes, right? Most of the people respond in predictable ways, but you've got people on either ends of the tails that respond in ways that aren't like most people. Edward, you stated in Facebook Live about 2 years ago that you save a sample of a PICL patient's bone marrow, so you later go back and test for a dose-response relationship. Could you test the quality function of patient cells after their PICL? We do save a sample in cryopreservation of not only every PICL patient, but every bone marrow procedure that we do, we tend to use that for research purposes because it's pretty resource intensive to test that either with a CFUF analysis, which would be a culture analysis of how many stem cells are in there, or a CD271 flow cytometry run. Both are pretty time intensive. So we'll do it for research purposes if we're trying to see if there's a dose response relationship between what's in the bone marrow and how that person responded. But that way we can take them out of cryopreservation, use some data that we published a couple of years ago, and then run 10, 20, 30, 40, 50 samples at once. Megan Bender, did you do a discussion of what happens in a telemed visit for a PICL procedure? Yeah, Megan, I'm so sorry about that. I didn't. I'll try to do that on Friday. I was down in Grand Cayman. It was pretty busy seeing patients on an ongoing basis. And so I didn't really have the time window to get into a live Q&A and do that. So I will do that, though. I apologize. I only did the Q&A last week because I know I hadn't done one in 2 weeks, and I was feeling guilty about it. Fatchin, turning and keeping head left or right for some time and getting dizzy. Could be a vagus nerve or jugular vein compression. Probably not jugular vein compression because dizziness isn't really a jugular vein symptom. But could be vagus nerve, could be related to any of those three things we talked about. The most common cause would be proprioceptive or bad position sense coming from the upper neck joints. Megan, did you do discussion? Yeah, got that already, Megan. Laura, what diagnostic test should I have to rule out vascular impairment? I have CCI, C1C2 overhang. Even when I'm in neutral, my C2 maybe drops, or O2 drops from 100 to 83 when on my right side. No history of surgeries. Well, the first thing certainly to get ruled out would be sleep apnea. I think that's what you're describing there. As far as vascular impairment, I'm not quite sure what kind of vascular impairment you're referring to, whether we're talking about internal jugular vein compression, vertebral artery, etc. Yeah, so the big things to rule out, obviously, as I talked about, are cardiac and neurological. Once those are ruled out, then we can get into this trying to figure out what's causing that, if it's related to CCI. And that can be due to lots of different things, like I discussed earlier in this lecture. Three biggest possible causes would be proprioceptive, vagus nerve, or somehow related to irritation of the vertebral artery. But it's very unlikely that there's severe damage to the vertebral artery based on the dozens and dozens of patients I've seen through the years that have that problem. Fatchin, if instability means vertebra is moving while person in motion. In theory, a hard brace should reduce all symptoms to zero if the person wears it all the time. Well, that's certainly one of the things that we use in trying to make this diagnosis. And it's certainly a helpful piece of information for us that if the patient locks out all motion, their symptoms go away. Now, realize that talking to some patients, their biggest issue seems to be that if their neck gets in certain static positions, even if it's not moving, that can cause symptoms. So I suspect that if we spent enough time, we could probably find a cervical collar that works for that person, but the collars they've tried aren't that great. Also realize that all collars are a two-edged sword, right? They can help to reduce excessive motion, but they also dramatically increase muscle atrophy, and those muscles are needed for stability as well. So wearing a collar all the time will make it much, much harder to recover from this kind of issue because of that muscle atrophy. Okay, any more questions for me out there? Happy to answer any more questions. I think we've got a smaller group today because I hadn't done this for 2 weeks and people got off the track of doing this at the usual time here. Oh, 2 more questions. It's been advanced by Megan. My doctor mentioned proprioception, but did not explain what it is. Could you explain, please? Sure. So realize that normal balance comes from coordinating 3 different systems. One is your eyes and the information coming in from your eyes. The other is the inner ear and the information coming from the inner ear. And the third is the upper neck. Now, when it comes to the upper neck, that's called proprioception or position sense. So position sense means that your brain is given the information of exactly what these bones are doing. Now, as you could see from a functional standpoint, it would be pretty important to coordinate all 3 of those bits of information or those inputs. So let's say it's 40,000 years ago and I'm trying to throw a spear at an animal that's moving across my visual field. The first thing that's happening is my eyes are tracking that animal. Second thing that's happening is that my head's probably turning at the same time as I'm trying to track that animal. Then I've got to adjust exactly where I'm going to throw that spear so it ends up where I want it by the time it gets to the animal. And I better have good balance and know which end is up while I'm doing that. And so that's a coordination of information from my inner ear, from my eyes, and from my upper neck that allows that to occur. But when one of those systems goes out, we have this mismatch. And for the upper neck, it's the body is giving bad information about head and neck position that don't agree with the information that's coming from the eyes and the inner ear. So the person gets dizzy. So proprioception just means position sense. And in this case, bad position sense from the upper neck joints that's not agreeing with other inputs coming into the system. So the brain gets pretty confused and it expresses that confusion by nausea, vomiting, dizziness, imbalance. Just like being on a boat, right? Maybe you've noticed that if you're on a cruise ship and if you're above decks watching the horizon go up and down, things are pretty good. It's really not until you go below decks where your eyes are saying nothing's moving, but your inner ear is giving your brain information that the world is moving up and down. It's that mismatch that causes the nausea. Giovanni, Dr. Schuster recommended I see McWhorter for rehabilitation. I heard you guys have worked with him before. I definitely get dizzy looking left, right. As Fatchin said, also when looking down. Would it be worth it do Dynavision, gyrostim, et cetera, to fix proprioceptive issues? It's certainly reasonable to try gyrostim. We've had one patient who sweared by it, Pam, who I interviewed a long time ago on this show. And so I think it's certainly something to try, just so that people understand. Gyrostim is an interesting thing. It was really designed more for athletes, and the concept is that you hold a little laser pointer pen and they kind of move you in different directions. So the machine has the ability literally to move you on your side, front, back, meaning you as a whole person, upside down, etc. And so it's a great exercise for coordinating all of these systems that we've been talking about while they're getting perturbed. Now, the big question I've always had is how many of our CCI patients would tolerate gyrostim? And that's still an open question. I don't really know the answer to that. Fatchin, does the poster corrector belt have a place in patients with instability or just a gimmick? I'm not sure what the poster correction belt is. So give me more info on that one. Scott, unable to get an answer from office using email, phone, or text, unable to make an appointment. I guess you don't want any new patients. Scott, if you're having any issues, then I will put, as I always do, my assistant's email below in the comments. Make sure I type it right. That just went into all the comments. That's my assistant's direct email. And so I would just bypass all that and go to her directly, and she can assist from there. For some reason that doesn't work, let me know. Dory, why does fluid pour out of eyes and nose when up, and especially when bending forward? Fused opposite occiput to T2. So I guess you're telling me that you're fused from the occiput to T2. Well, I mean, given the size of that huge fusion surgery, the first big problem to be ruled out would be that that's not a dural leak with that size of surgery. So that probably needs to be ruled out. So that would be the first thing that comes to my mind. Obviously, if it's ruled out, then you can get into other types of things. But that's a huge surgical procedure where dural leaks are not uncommon. So that's the first thing that probably needs to be ruled out. Sherry Kopp, is there any chance that CCI-like symptoms would eventually heal on their own? The only thing offered here in Europe is surgery. I think we have patients who injure the upper cervical ligaments and they heal up. I've even seen some patients who are further down the road where they've restored their curve and then their ligaments have healed up. So it's certainly possible to have happen. No, Scott, we are live. It's 1:37 p.m. Mountain, according to my computer. So I'm hoping it's whatever that, wherever you are. But I will give you a warning because we don't tolerate trolls here. So if you start trolling, I'm going to avoid you. Giovanni, you mentioned that dizziness occurs when the eyes, ears, and neck can't agree on the signals being sent. Are there any medications patients are ever given to cope with the dizziness until instability is fixed? Not really that I've seen. Obviously, there are medications that could work. There are nausea medications that can be taken. Zofran's a good example of that. Scopolamine patches have been used in instances of seasickness, etc. Obviously, that's not a long-term solution, and then those medications are all highly anticholinergic, so they bring with them some other sets of issues. SPRY posture correction, SRY posture correction belt that you wear on the back. One of those sold on Amazon. Let's see. Let me pull up Amazon and see what we're talking about because I don't know that one in particular, and there's so much these days that's sold on Amazon. Let's see if I can share my screen here. Let's see what we got. Got a posture pump, posture correctors. Yeah, I mean, when it comes to these kinds of posture corrector things, I haven't been all that impressed with how patients tolerate them. So I would say that if you're going to do something like that, there are computerized systems that probably work better. But are more expensive. Let's see here. I guess there's a bunch of them now, but these computerized systems, like this one, there's also more expensive ones that are sold out there. Those might be better, at least in reminding you when you're having a bad posture, rather than trying to force a posture in, because I think that can cause other problems in some patients. Okay, guys, other questions I can answer at all here today. Dory, so best way to find dural leak is MRI. It's my adult son. Can the fluid be collected to see if it's CSF fluid? The fluid can be collected. It can be tested for a certain protein composition to see if it's CSF. That's frequently called a pledget test. So they'll put, a piece of gauze up there, try to collect it in the gauze, and then send it out for testing. That's probably a good place to start. Obviously, MRIs can be done to see if there's small fluid collections, and if the dural leak is brisk enough, you'll be able to see that. The problem is it's harder to see if it's a slow dural leak. And the other problem will be that all that hardware will cause a magnetic artifact, so it'll be hard to see. So I think I'd start with the pledget test. And there are doctors out there that specialize in finding dural leaks that can do those pledget tests or send the fluid out for sampling. So that's probably where I would start, in that it has the highest likelihood in that situation of either sending you down the right path or avoiding a lot of looking that may not find much. Obviously, a routine cervical MRI would be helpful as well, just to make sure it's not a big leak. Fatchen, I've read that prolotherapy is more suitable for painful conditions where the ligaments are mostly intact. PRP and others better for regenerative weak ligaments. How come some CCI patients claim to benefit a lot from dextrose? It's a question of small percentage of success. So if you've got, well, let's talk about two things there. The first thing is where we're putting the prolotherapy. So if you have instability in flexion, that would be treating these ligaments back here, supraspinous, interspinous, nuchal ligament. And simple prolotherapy of those ligaments can help tighten them. And that can help reduce that kind of instability. Now, if we're talking about more C1, C2 side-to-side instability, or instability that's related to internal ligaments like increased ADI and the transverse ligament, that's not going to help so much. So prolotherapy is good at tightening loose ligaments. It can also kick off repair. You just need to do a lot more of it to get similar results to something like PRP. So that tends to be the biggest issue. But yeah, if you've got the right type of instability, prolo can work very well. Scott, I have moderate atlantodental osteoarthrosis, non-inflammatory with osteophyte seen on CT, intolerable pain and gagging sensation that correlates with pain over ADI is normal. Yeah, so if I think you're saying you've got C1, C2 arthritis, and C1, C2 arthritis can be treated usually through an injection of the C1, C2 joint, depending on how severe that is, either with PRP or with bone marrow concentrate. Obviously, if it's end stage and there's severe loss of cartilage within the joint and large osteophytes or bone spurs, then, that may be in a different category. I'd have to see it. Giovanni, do proprioceptive issues disappear once instability is resolved, or more rehabilitation needed? Usually both. Excuse me, guys. Levon, is it possible to have an increased intracranial pressure yet not experience headache? I suppose it's possible. Again, diagnosis of increased intracranial pressure is not an exact science. So most of the time that gets diagnosed from a lumbar tap or a spinal tap in the lumbar spine. But obviously that's not telling us too much about what's going on up here locally. So that's one of the reasons why I don't like that diagnosis as much, because it's a hard one to make, and it's not one that we can, run this test and clearly show that that's what's causing your symptoms. Giovanni, do proprioceptive issues, dizziness resolve once I got that one, I think. So yeah, Giovanni, not uncommonly. So many times they resolve, but sometimes more proprioceptive retraining is needed. Scott, is your diagnostic test being done for this? Could it be from alar ligament laxity? Conventional pain doctors said no way to test this joint. Yeah, C1, C2 joint can be injected. You're just not at a pain doctor who has experience in injecting that joint. And that's not uncommon. There's nothing wrong with the doctor. It's just a procedure that not many providers have experience with doing. So for example, if we take a large area, I don't know where you live, but let's say a large area like Metro New York, right? Millions, tens of millions of people live in Metro New York. We'll probably have one or two physicians in that entire area who have done C1, C2, or C0, C1 injections more than a dozen or 2 dozen times in their whole career. So none of them are all that excited about doing that procedure that they don't really do on a day-to-day basis. You know, we've done it thousands of times, so it's routine. There's not a week that goes by that I'm in the clinic that I'm probably not injecting 3, 4, or 5 C1, C2 joints. So yes, it can be injected to determine if it's causing symptoms, but that injection is an area of specialist expertise, and it's not something you're going to find at your average interventional pain doctor's office. HRH, how many months after PICL will almost all improvement occur? You know, we look at 4 months, but it's possible that it could go longer out in that tail of the curve that we're talking about. Scott, how is the pain at atlantodental joint? I think you mean atlantoaxial joint. If you mean the atlantodental joint, there really isn't an atlantodental joint per se. There's a bursa there. So I'm not quite sure if you're talking about the atlantodental articulation where the C2 dens meets the atlas, or you're talking about the atlantoaxial joint, C1, C2. So you'll probably need to tell me which of those you're talking about. One is up front, the other one's in the back here. Stephen, Helen External often read on the internet that you need a paleo diet to prepare for stem cells. How important that from your point of view in relation to stem cells? Yeah, I'm not sure a paleo diet, but you certainly want to eat healthy. And healthy these days is getting rid of sugars and starches and simple starches from your diet, and sticking with whole grains and no added sugar, or as little added sugar as you can tolerate. So I think it's not so much a paleo diet as much as it is just eating what I would call healthy. Obviously, that's not bread, that's not pasta, that's not Diet Cokes, etc. Yes, Scott, I need a little more information. I try to answer your questions as best I can. Fetching, can tethered cord mimic CCI-like symptoms? Symptoms-wise, there's a clear difference between CCI and tethered cord. So Fetching, we're talking about not tethered cord, but I think you're talking about a Colt tethered cord. Tethered cord is when on the MRI, there's clear evidence that the spinal cord is pulled down. That's really not what we're talking about when CCI patients mention that diagnosis. Really, we're talking about a Colt tethered cord, which is a very, very controversial diagnosis that 99.9% of neurosurgeons don't believe even exists. And that concept is there's some extra tension on the cord, but it's impossible really to diagnose because it overlaps with so many different things. So no, there really isn't a big overlap between a Colt tethered cord symptoms and CCI. And it's very, very hard to diagnose a Colt tethered cord. The only way really to diagnose it is to cut the bottom of the cord, the filum terminale, and see if the symptoms go away. Obviously, that's a big surgery to do that. I don't know what you mean by it's the medial joint. So we're talking, Scott, about 2 different joints here. So the C1, C2 facet joint. Is going to be the joint between C1 C2 here. There's also an atlantodental articulation, I guess you could call it, between where the dens meets the atlas up front. Only medial joint. So I'm assuming you're talking about the medial aspect of the C1 C2 joint. Patrick, Dr. Schultz had a PICL procedure back in June 2022. Recovered 100%. My issues were extreme vertigo, increased heart rate, severe fatigue, brain fog, body seizures, vomiting, eyesight issues, headaches, and general body instability. You guys saved my life. Well, thank you, Patrick. Great to hear from you. And I'll certainly relay that to Dr. Schultz, that you had such a great result. And, it's always great if you can answer questions. That would be wonderful, because as you probably know from being a patient with this kind of thing, it's a little bit like being lost, and it's helpful to talk to other people who have had good success with certain things, and to be able to ask them questions about what they experienced. So that would be wonderful if you're willing to do that. Edward, is the 7 and 10 response rate calculated from 3 to 6 month follow-up emails you send out the patient after the procedure? No, it would be an overall success rate. So by the time we get to the end, putting that person either in the box of didn't really respond to responded in some substantial positive way, that means they're not going to move on to surgery. Melody, maybe? Buskin. What about neck stretching, relaxing pillows made of plastic to help correct the curve? Also, what about neck strengthening exercises to help heal? So what I find with cervical pillows is they're pretty individual. Some patients love certain ones. Some patients hate certain ones. So the biggest thing I think you can do there is to experiment with different things, maybe using a towel, and find out what kinds of shapes work for you, and then maybe purchase something inexpensive and try that out. Neck strengthening is always a great idea, but many of our CCI patients crash and burn with neck strengthening. So that's almost one of the things that helps to make the diagnosis. Talking about the odontoid process, the medial joint, there are facets in the center where rotation occurs. Moderate osteoarthritis was found there. Yes, Scott. So I think you're talking about articulation between the atlas and the dens up front. But, listen, best to try to get a telemedicine set up with Carla. I think I put her email above there, and we can look at the images and try to see exactly what it is we're both talking about there. Elizabeth, are there any head supporting braces or equipment that you have found to be helpful? My head, not my neck per se, feels like it needs support. Yeah, just be careful there, Elizabeth. It's certainly okay to use that kind of thing, a head or neck supporting collar on an intermittent basis. But if you use it frequently, it's going to cause a new set of problems, which is going to be muscle atrophy, which is then going to make overall recovery much, much more difficult. Stephen, I suspect I have tethered cord, but I'm not sure. Do you think it makes sense to have this treated first and then get stem cells? No, that makes no sense at all. Again, as I often say, there's a ladder of invasiveness here. So that means you do the next thing up on the ladder, that's the least invasive. And then if that doesn't work, you go to the next invasive thing. Tethered cord surgery is huge surgery, right? The doctor's making a permanent biomechanical change to your neurologic system that can't be undone, and has to go into the area of the spinal cord to cut where the spinal cord anchors. That's neurosurgery. So injections always come before neurosurgery. So no, that would be backwards and expose you to far more risk than you need to. Plus, we would then be making a permanent biomechanical change to your central nervous system that could never be undone, meaning once we reduce that anchor for the spinal cord, everything about the biomechanics of the central nervous system changes, and there's no way to go back. So we would only want to do that if, number one, we were pretty convinced that you had tethered cord, and number two, that you had tried everything else short of highly invasive neurosurgery. Elizabeth, meaning helpful for managing short activities throughout the day. Again, two-edged sword. The answer is, if you find something that helps, great, but I would only use it very intermittently to assist. Giovanni, I had PRP about 2 months ago and got slightly below my prior baseline after the procedure. And recommendations to improve this. Am wary to try PT. Say, heard it can interrupt healing. Which muscles are best to strengthen for stabilizing? Yeah, Giovanni, I'd need to know more about, when you say PRP, that doesn't mean a lot to me, in that I would need to know exactly where they put it, how they put it there, who put it there, what kind of PRP were we talking about, et cetera, et cetera. But having said that, when it comes to strengthening, you can certainly start to do strengthening at this juncture, 2 months out from something like that. Fatchen, the alar is responsible for lateral bending and neck rotation too. So the alar would be activated if you're lateral bending or in rotation, and it would share a load with other ligaments, and not the only ligament, but it would take the brunt of those loads. Scott, you're able to access images from UC Health Denver when I visit your clinic, or do I need to get them myself beforehand? We can, but the problem with that is that's not a professional viewer. That's a patient viewer. So you would need to let my staff know that your images are there, and they will have to download them to our system so that we can view them in a professional doctor type viewer and not the patient viewer. Gotcha, Giovanni. So then I would go ahead, and certainly a good time to try strengthening, but run that past Dr. Schultz, because he knows more about your clinical situation, obviously, than I do, and whether or not that's appropriate. Okay, guys, so we're coming up on an hour here. I appreciate all the great questions. I'll take one or two more questions, and then got to get going to another meeting. So again, just to review what we talked about today, I talked about the causes of this graying out or fainting. The good news is it's rarely something that is potentially fatal. So when you hear that kind of thing on Facebook, that's generally not what's happening. Obviously, there are big bad things that need to be ruled out. But the good news is the medical care system is pretty good at finding those big bad things. And if you've had a workup for this kind of issue and it's come up negative, including MRI of your neck and your brain, then it could be related to your CCI. And that can be related to those three things we talked about, the vertebral artery, or proprioceptive issues, or problems with the vagus nerve. And then one last question here. Should have a PIT be stopped before posterior PI injection or PICL, because that's a medication that stops and resume gradually when prescribed? Probably not stopped, just because I think it's probably better just to play through on that. Now, you'll probably have to stop it, meaning skip your morning dose of it for the procedure itself, but you would be able to take your afternoon dose right after the procedure. Okay, guys, thanks so much for watching today. I'm back on the normal schedule now. I'm back in the U.S., so that means that I'll be here on Mondays and Fridays, the best of my ability, at 1 p.m. Mountain, 12 p.m. Pacific, and 3 p.m. Eastern, 2 p.m. Central. And obviously, we'll try to get to as many questions as I can. I think I will do this Friday, the Promise lecture on how to prepare for and what to expect in a telemedicine visit, because I didn't get to do that last week just because of how my schedule was running down in Grand Cayman. So thanks so much for your time today, and thanks for all the great questions.